Hi everybody, welcome to Fertility Fact or Fiction, the show where we dispel all the myths and share all the truths about infertility and try and support our patients through their journey. So we've got an interesting topic this week, something that I've been starting to look into at the request of some of our patients about doing minimal stimulation IVF, and that's where we give a lower dose of medication in an attempt to try and get the sort of overall best outcome that we can without having to use a ton of medication. So ideally, in any kind of given fertility situation, you want to keep the cost as low as possible. You want to keep the exposures to medications and treatments as low as possible. And that's to make it as easy for the patients as we can. So they discovered this whole, or sort of proposed this whole new approach, which was instead of giving lots of medication, giving much less medication in the hopes that we get the best outcome possible. So there's a new study that's come out that basically says how many eggs do you need to optimize those results. And that study is still in the pre-proof stage, but it was really interesting enough that I thought I would share it with you tonight, and we can go over what all of that shows and it means. So as usual, grab your tea or coffee or hot chocolate and join us for the show. And after the presentation of the important stuff with the science, we'll answer all your questions live. So if you have questions, you can start posting them now. We will get to them. We always start from the ones that are posted up first. And we've had a couple of people pre-post for us as well. So don't hesitate if you have questions, put them up there and we'll answer. So in terms of this study, this was done over 4 years at 5 different fertility centers. And the idea behind minimal stimulation is to use a low dose. So this particular study chose between 100 to 150 units per day of gonadotropin. So whether it was Gonal-f or Menopure or whatever, they were using 100 to 150 units per day. So traditionally, we'll tend to use a higher volume in the vast majority of patients. There are not really a lot that we use very low dose in that, that range for, with the exception of patients that don't want to produce very many eggs for ethical or moral or religious reasons because they don't want to freeze out too many embryos or freeze too many eggs, or when we have patients whose ovaries have already been tried at the higher doses and don't respond. If you're only producing 2 or 3, taking tons and tons of medication isn't going to suddenly make you make 10. You're still going to probably make 2 or 3, so there's no reason to invest in all the extra medication. You may as well use that money towards more cycles. So interestingly, in this particular study, they did something a little different, which is rather than using mini-stim for patients that have diminished ovarian reserve or lower egg reserve, ovarian reserve, they actually chose patients that were either normal or high responders. So minimum AMH was 7. They wanted the patients to have at least a reasonable number of eggs. And so they were really looking at trying to optimize the outcomes by comparing what the number of eggs you would need if you're a normal responder would be to get a reasonable live birth rate. And they're kind of approximating around 40 to 50% as being their definition of what was a reasonable live birth rate. And that certainly is a reasonable live birth rate. So when we analyzed this, they had about 1,048 cycles that they included. 628 were fresh, 239 had freeze-all cycles as well, but quite a high number of fresh compared to what we are normally used to. The basics of the IVF were pretty routine in terms of everything that we normally see, and so there weren't a lot of differences in terms of the actual technique that was used. It was more or less pretty normal. So there's a couple of parts to this that are kind of important. So number one, it's actually quite conflicting in the data as to whether or not mini-stim gives you the same success rates as normal or conventional stim. There are some studies that have come out that say it does, and there are actually a number of studies that have come out that show that it does not. And then there's one meta-analysis that says mini-stim actually gives you a higher success rate than conventional stim. So the jury is still out. We don't really know. I know several years ago at a meeting in Chicago at the Midwest Reproductive Symposium, there was a presenter from Harvard, from Boston IVF Group, who presented, and he basically went through the data and said there is no question that when you make more eggs, you make more embryos. When you make more embryos, you have a higher chance. But there are actually some studies that say that that is not the case. So again, it's very controversial right now as to whether or not mini-stim really does help you in some way, or whether it's just kind of another gimmick. And keep in mind that if you don't produce enough embryos, even though you may have only paid a couple $1,000s less, like maybe $1,000 or $2,000 less than a conventional cycle, you are in some circumstances going to need another cycle. And so that actually kind of doubles what you had to spend compared to spending a little bit more and doing a conventional IVF cycle. So the cost-benefit ratio is not necessarily always there. So we're going to go to figure 3. I'm going to kind of jump ahead in this one, and we're going to talk about what that shows. So it should be, am I minimized in a corner somewhere? I'm way over there in the corner. Okay. So as you can see, there's a whole busy kind of slide here, and I apologize for how busy it is, but I didn't design it, so you can't necessarily blame me. So at the bottom there is the number of eggs that were produced, and then at the side it's the percent of live birth rate. And then they have the blue is the live birth rate from fresh, the orange is just clinical live birth rate, and then the green is the ones that included the freeze-all cycles. So what these authors concluded from their data analysis was that once you hit 9 eggs retrieved, then you're kind of beginning to plateau as far as your success rate. So you can see if you just get 1 or 2, your success rate's about 15% for live birth rate, and the clinical live birth rate and frozen embryos was a little bit higher. There you're looking at, or sorry, the conventional, not clinical, you're looking at about 30%. But when you looked at this in terms of the overall scheme, you can see it's kind of like that nice little curved graph. And it starts to plateau, according to the authors, around 9 eggs, and then starts to kind of begin gradually to go back down. Now, it looks like it goes a little bit higher, but then when you analyze the actual numbers, this is just an approximation of all of those changes in the bar graphs. So they said actually somewhere between 9 to 12 was the ideal number of eggs to retrieve. Why is this important? Well, it's hugely critical because when you look at this, it sounds like mini-stim may be great, but in order to get roughly a 40 to 50% clinical live birth rate, a live birth rate, you actually need to have 9 eggs retrieved, and they go on to say it actually ends up being representative of about 4 to 5 embryos. So with most mini-stim cycles, they're not necessarily being applied to patients with normal response. They're often being applied to patients with poor response, where patients think that if they take less medications, they're going to have a better outcome. The problem with that is, according to this study, you actually need a minimum of 9 eggs or 4 to 5 embryos to get close to what you're going to get from a normal conventional approach to IVF. So with that in mind, it's really critical to make sure that when you look at this data or someone's proposing something to you, that you understand where the data is coming from and where the research is coming from, because this applied to normal responders where making 9 eggs, even with a low amount of stimulation, is actually quite a realistic outcome. But if you tried this on someone who has diminished ovarian reserve, it's entirely likely, not just possible, but likely that you won't get 9 eggs. And therefore, mini-stim in those circumstances is going to fall far short of what they're projecting here to be necessary to end up getting you to that live birth rate that you want. They also do something that I've never seen before, or at least traditionally don't see, which is when you go into table 3, if you don't mind. So table 3 is actually a review of what they found in a number of different studies that they looked at. So 2019 from Connell, they said there was no upper limit to the number of oocytes to optimize conventional, but for the live birth rate from mini-stim, 11 to 15. 10 to 12 from the Chen and et al. Study for optimizing live birth rate. Dracopoulos, they said around 21. G, 6 to 15. Magnuson, 11, 7, and then 15 and 15. You guys can all see it there in the table. Why is this critical? Because these studies are suggesting in the majority of them that you need even more than the current study is showing, in which case the mini-stim will often take more than one try, right? So now you're talking about doing 2 cycles of mini-stim just in order to get the normal number of eggs to match what you would get from a live birth rate standpoint with conventional IVF. And the critical element of this, the part that's so important for everybody to remember, is this is applying to normal or high responders. So if you're in the low response group and someone is telling you, oh, you should try mini-stim, this is the way to go, you know, we can save you loads of money on the medications, or the medications have bad side effects and that may be hampering your egg quality, the answer is that's scientifically not that sound, because you actually need a lot of eggs to achieve a reasonable degree of live birth rate. And even then, in these studies, they're all looking at around a 50% success rate. So make sure you take everything that is said to you with a grain of salt, because mini-stim can be useful and approximate what you get from a conventional IVF cycle when you do your IVF with enough ovarian reserve to get a reasonable number of eggs, somewhere between that kind of 9 to 15 eggs. But if you're doing your mini-stim because of the fact that you're worried about the impact on your ovaries or the impact on your egg quality, or you have diminished ovarian reserve and your ovaries are not going to respond that well, there is no guarantee that you are going to have the same kind of live birth rate you would from a conventional cycle, because you're probably going to produce far fewer eggs than is necessary. We're not going to get anywhere close to that 9 to 15, and therefore you're not actually getting the same rates of success. So it's not apples to apples sometimes, it's apples to oranges. And that's why I feel so strongly about sharing this data with you guys, because all too often you'll read mini-stim is the way to go. Somebody says, oh, I did mini-stim and that's what fixed it for me. The reality is it was probably blind luck and it had nothing to do with the mini-stim. Now, I do think there's a lot of interest out there in seeing over time if mini-stim can end up giving you a cumulative live birth rate that's significant, and that in that regard you can get a higher chance. But the reality is that we don't know for sure exactly how many cycles you need to do, how many times you need to do it, or even what method needs to be used to optimize your success rates yet. And I think they really need to come out with an ideal randomized controlled trial that takes mini-stim and also takes the conventional and compares it head to head, usually with a freeze-all, maybe doing the PGT. We still don't have that yet, and hopefully someone will do that soon. So is it a fact or a fiction that mini-stim can solve your fertility problems? It is not a fact for sure. It's probably a fiction, because mini-stim will help patients that have normal or high response have almost the same success as the group that has normal ovarian reserve and is doing a conventional cycle. But for patients with poor ovarian reserve, who are often the ones trying the mini-stim, it's not likely to yield enough eggs, and so you have to be very, very cautious in doing that. So make sure you like, comment, and share. We're always looking for people to spread the word about what we do, and if you have any comments or have any questions about the material that was presented, don't hesitate, let us know, and we will be happy to go over that with you. So we're going to turn now to the answer portion of the show, and we're going to take your questions live. So I think Tarek will be reading them out as usual, and I'll do my best to answer. And I hope you like that show.
My nurse said that letrozole works best after 3 months. Is that true?
No. So it can take a little while for your ovaries to kind of kick into action, but there is no evidence that I'm aware of that says that letrozole works better in the 3rd month than it did in the 1st or the 2nd. The one warning or caveat in that is that it doesn't always work at the first dose that we use, and sometimes we need a month or two to adjust the dose till we get it to the right amount for you to actually even get the letrozole to work, especially if you have PCOS. So there can be a little bit of an opportunity for us to need to adjust, and that could make a difference. But certainly there is no evidence that supports the idea that you need to wait 3 months for letrozole to really kick in.
Tomorrow will be 2 weeks since my IUI, and I'll be taking a test. I took an HCG trigger shot the day before. Any chance of a false POS from trigger or neg? We'll be doing blood work later this week.
No, HCG washes out of your system typically within about 5 days, even on the long end about 6 or 7. And by the time you test at 8, 9, 10, 11, usually 14 days, it should be well clear of your system by then, assuming you haven't been taking any HCG in the meantime. So if you have a positive HCG all the way out on day 14, there is no way that's from your trigger shot.
During a saline sonohystogram, found a fundal submucal fibroid with indentation to the cavity of 0.7 by 1.3 centimeters.
Sure.
Entire fibroid is less than 2 centimeters. They say must be removed.
Yep.
Should I try to get pregnant?
No, you should get it removed because it's a huge increase in failure and a huge increase in your miscarriage risk. So your miscarriage risk goes up almost 100% over what it already is, and your failure rate is much, much higher. So it's a 50% reduction in success when you have a submucous fibroid. And submucous fibroids are honestly a joke to remove. It's very easy surgery as long as you have a good surgeon. They're very straightforward, very safe. The size that you're talking about is very small, so it's very, very easy to do.
Can you explain the live birth guarantee IVF package you offer? What is the criteria, and does it include Pgt testing?
Okay, so we offer a variety of live birth guarantees. We have one for autologous where it's the man's sperm and the woman's partner's eggs. We have one for our egg donation program, and we have one for our surrogate program. And then we also have one for our egg donor and surrogate program. So with the live birth guarantee, there's some important things to understand. Number one, we don't provide any different treatment than we do with any of our other cycles. All our patients get treated the same. It makes no difference to me whether you spend $0, $1, or $1 million. You're getting the exact same treatment for us because we don't do things based on money. So that's number one, and that's really critical to understand. Number two, and equally important, is that with the live birth guarantees, we are not guaranteeing you a baby, we are guaranteeing you the money. So you either get a live baby or you get your money back. So it's not a guarantee of having a child, it's a guarantee that we're gonna do our best like we always do, but it's an insurance policy for you which basically says, look, if I don't get a child out of this, and the child is a baby that is born after 24 weeks and lasts at least 30 days, that you get your money back out of it. So, or at least another try. And then if that still doesn't work, you still get your money back out of it. So we have a really robust, very patient-friendly guarantee program. The nice thing about it, a lot of the reason people don't succeed in IVF is actually stress. And when they do the guarantee programs, there's no stress because you're either getting a baby or you're getting your money back. So it very rarely fails because people have no stress with it. And because of that, we love it because the patients love it and they're very comfortable with the process. And admittedly, no one ever looks back and tells their kid, you cost me $10,000 extra, because once they get to university, they're going to cost you hundreds of thousands of dollars extra. And so it doesn't really make a big difference what you paid for them 20 years earlier or 18 years earlier. So the criteria we use depends on which program you're a part of, whether it's the donor or autologous and so on, but it would take forever to go over it all. Essentially, we need to make sure that there are no major issues which would prevent us from succeeding for you. So for example, if you have severe endometriosis, your weight is very high, the sperm is extremely poor quality or has very high sperm DNA fragmentation parameters, we don't guarantee those cycles because we can't guarantee those cycles. We have to have some kind of reasonable expectation that the success rate will be high enough to justify doing the guarantee. That's not to say that we are so picky that we know every single patient is going to succeed, but we know that every patient that is trying the guarantee program has at least a reasonable chance of success. And that's something we calculate internally, and we do take it on a case-by-case basis. So I have had patients say, look, I don't fully fit the criteria. Will you consider using us for the guarantee anyways? And sometimes we do, because on review, we'll feel strongly enough that those patients deserve to have a shot. So it's not something where we just kind of smash down these rules and say, hey, this is it, and if you don't qualify, you don't qualify. We're a lot more flexible than that, but at the same time, we're careful. And I will say that the guarantees are kind of the hallmark of our program. Although we are doing so well right now and our success rates are so incredibly high, I'm not sure we need to have people do the guarantees, because pretty much almost everybody's getting pregnant these days. So we have had a very, very good success rate. Our embryologist is absolutely phenomenal, Dr. Khosravi. We love her. She's amazing. I just posted last night, and it was well worth the mention that in 2 very recent cases, she got not just 100% fertilization, which she gets pretty much all the time. She got 100% blastulation, which means not only did every egg become an embryo, it actually made it to the blast stage. So that's unheard of. Like with our last program, we never got that. And I haven't seen that from any of the other programs I've been working with either. So it's a really robust program. We're getting excellent results. We've really nailed down our embryo transfer protocol. We're putting it in exactly the right place, and we're doing a great job with that. So we're having incredibly high success rates. I went to talk to my embryologist about tweaking part of our embryo transfer, and she laughed at me and she said, we're getting 100%. Are you trying to get 150? Which obviously isn't possible in this scenario. So, I think we're doing really well. And so the guarantee is great if you want a stress-free approach to things. It's wonderful. But is it necessary or mandatory? No, not at all. We're doing a great job for everybody, and I'm not going to treat you any differently. Last thing to answer is the Pgt included? It is included in the cost, but if we fail, because we're actually paying a lab for that testing, if you insist on Pgt and you don't need it, in other words, you're less than the age of 38, we actually don't refund that portion. Over 38 we do, but less than 38 we don't refund the Pgt portion.
Okay.
Long answer, sorry.
I was in it all the way. Hi, Dr. Victory. Are you awake?
That's good.
Are you aware?
I am awake, I assure you.
Are you aware of any newer data with regards to safety of vaccines in pregnancy, in particular the mRNA ones?
Yeah.
Thank you.
So we know so far that there has been no data to demonstrate that the mRNA vaccines are harmful. So I think I kind of need to explain how these are made. So what they did was they actually figured out what the protein coding of a portion of the spike protein on the capsule of the virus was. Okay, so the virus is like a sphere, let's say hypothetically, and it's got this little nub, which is this spike protein, and they took that protein and they figured out what the sort of amino acids that are linked together in that protein were, and there are codes in RNA that correspond to specific amino acids. That's how proteins are made. So they actually made the reading strip, so to speak, the instruction set in RNA to produce that small portion of the spike protein. So what you're actually taking in an mRNA vaccine is that mRNA. The mRNA goes into your cell, it lands on ribosomes, and the ribosomes start producing it, or theoretically it could go into your nucleus, become complementary DNA, and then it reruns into becoming RNA, which then becomes the protein. So essentially it is teaching your cell to produce a small fragment of the spike protein. Once that fragment gets out into your blood, your blood looks at it and goes, your immune system goes, this doesn't belong here. So it makes an antibody to that portion of the protein, except because it's making it to a portion of the protein, the antibody can actually bind to the protein. So if you're exposed to coronavirus, you've already got antibodies ready to attack the coronavirus, and therefore you're protected from having severe side effects because your immune system's ready to shut it down before it can get you sick. So how does that translate into pregnancy? It doesn't. It makes no difference whatsoever if you're pregnant or non-pregnant, because all you're doing is getting your cells to produce a small little chunk of a protein that has no individual effect on its own. It's literally got no effect. So pregnant women can take the vaccine without any harm. And we've actually seen now literally dozens of women within my own practice who have worked in the hospital system and are our nurses or healthcare staff, and who come to see me for their obstetrical care and already are pregnant and are getting the vaccine with no side effects to their pregnancy or to them whatsoever. So there's no safety risk. The other material, and we have a great video on this on our YouTube channel. I think it's called the COVID Vaccine and Fertility. So you can watch that. It's got about 28,000 views. Make sure you check that out. We already talked about this point there. And that is that the stuff you read about on the internet is complete bunk or garbage as far as this is going to cause infertility and this is harmful. I had one long debate with a young lady who was, in the strongest sense, completely convinced that the studies were not done properly. Look, there are loads of flaws with every study, and I'm not saying these ones are exceptional and flawless. But the bottom line is this prevents people from getting severe COVID symptoms, which can kill you. And it has absolutely no relationship whatsoever to fertility or infertility. In fact, there is some growing evidence that men that get COVID actually have a decrease in their sperm performance for some period of time. So if anything, getting vaccinated for guys will improve it, and for women it has no downside whatsoever. So as far as we know, it is safe. There have been 30 patients during the trials that were vaccinated who either became or were pregnant at the time, no side effects. We've now had probably more than 30 patients that have been vaccinated. Again, no side effects or any problems with the babies. So I have no hesitation telling people to get it. You just have to wait 2 months from your first vaccination before you get pregnant. So if you're not pregnant now, you're TTC, and you want to get the vaccine, go ahead and get the vaccine, but you have to wait 2 months from your first shot just because it is stimulating your immune system, and that's not a great time to get pregnant. It's okay to be pregnant, but it's not okay to get pregnant.
If you want to point right over there, other side. That's your COVID videos right there.
My COVID video is right there. Tarek's putting it up while we're doing it. So click on that link, and that'll take you to the COVID video where we spelled all of this out in detail.
Whew.
That was good, man. On the fly. Well done. Big round of applause for Tarek. Lots of thumbs up, likes. Send some love to Tarek. He's a great guy.
Okay. Where to go? Okay. AMH 3.3, PCML over ML.
Okay, PMOL. Yep.
Yep. If chances of natural pregnancy at 40 is 5% every month, and so is IUI, what would you recommend? Skip IUI and go to IVF, or just give up? My mom and my sister at 39.
My mom and my sister at 39? Meaning they gave up at 39? I don't know. Okay, great question. So
they got pregnant at 39?
I don't know. 3.3 picomoles per liter for AMH at 40 is going to be tough. You should watch our embryo math video, which Tarek will put up on the other side in a minute. Yeah, where we go over this kind of thing so that you understand exactly what to expect. So at 40 with a low AMH like that, you're likely going to produce 1, maybe up to 3 eggs maximum. If you are able to produce 3 eggs, you can estimate at a good center that they'll be able to get all 3 of them fertilized. 1, maybe 2 of them will reach blastocyst, unless you've got the amazing Dr. Khosravi that we do, in which case maybe all 3 will make it to blastocyst. But realistically, blastulation rates are usually 50%. So when I got ready to do the embryo math video, the lowest study I found was 30%, which no one would tolerate, and the highest was 70. So, you know, if you're looking at an average between 30 and 70, you're at a 50% rate. So if you get 50%, you're really looking at 1 or 2 embryos from your 3 eggs that make it to blastocyst. And then we know at that stage that somewhere around 70 to almost 80% will be genetically not normal. So that means you actually need 5 embryos in the hopes that one of them is normal. Now, it doesn't quite work out that way mathematically, but somewhere between 4 to 5 embryos with the hope that one of them is normal. Now, you could end up with multiple normal, you could end up with none that are normal, but you're hoping that at least one is normal based on those numbers. So realistically, you would have to do IVF a minimum of 3 times in order to get 4 or 5 embryos, hopefully, maybe more, because if you only produce 1 blastocyst, that's like 5 times. So you need to try IVF several times in order to be successful. Can you eventually be successful? Yes. Can it happen on first try? Yes. Is the chance high? No. So those are situations where we sit down, we have a long talk with you. I explain the success rates, the outcomes, the chances. We talk about alternatives, things like donor egg or doing IUI or adoption even, and not doing anything. So it's not that I encourage people to do nothing, and I never want to dash anybody's hopes. So if you want to try, I am 100% supportive of your effort to try. But I'm also 100% going to make sure you know the truth about what you need to expect, because all too often in this business, I find that people go other centers where all they care about is the money, and instead of telling you, look, your chances are 5% or 10%, or you need to do it 3 or 4 times like I'm telling you here, they just say, yeah, you should come and try, let's try. And then when it doesn't work, they say, oh, well, you're 40 and your AMH was low, you got to try again and again and again. And then you've already paid, now you're upset, you didn't know what to anticipate. And at that point, it can become very burdensome emotionally, psychologically, and financially for sure. So we always make sure we're honest with you to give you the full story.
Have already sent my doctor's referral. I need a small fibroid removed. When would you be able to see me and possibly remove my fibroid?
So you know what, I'm going to try not answering those questions online because my office administrator, Mara, is going to kill me. So we really don't know, especially with surgery. We get you in as quickly as we can, but I think we're going to stop answering those questions online, guys. We do get you in as fast as possible, and if it's urgent, let us know. You can always call the office and leave a message, and we will do what we need. But keep in mind that it actually genuinely has to be urgent, or the lovely people that run this place will put you to the back of the list if you try and squeeze through with something that is not urgent. So we are quick, we're very efficient. A lot of that is because I work 24/7. I'm here on weekends, I'm doing consults on weekends. I don't stop. So I'm always available, but there's only so much we can do. We do have the amazing Dr. Carrie Mayran joining us shortly, and she'll be taking over a lot of stuff to free me up to do more, especially for the surgical cases. So we'll catch up to you quickly, but the surgical time is tough right now. We may even need to send you to Toronto to be done in the Create Fertility Center, where I do some of the minor surgical stuff that we need to do.
Yeah. Actually, let's go here.
Okay.
Instagram.
Oh, one of our patients asked us if she has normal sugar levels and her BMI is 27, but she can't lose weight from PCOS, and she's working out with HIIT training 5 times a week and eating healthy, what should she do, and would metformin help? Okay, so first of all, if your BMI is 27 and you're doing HIIT training, keep in mind that muscle actually weighs more than fat. So your body mass index based on your weight may be a little bit higher, but if you're a lean 27, that's actually okay. So that's not a problem necessarily. The part of body mass index that's concerning for fertility specialists is the percent of body fat. It's not so much necessarily the exact number. I mean, obviously there's some correlation, but if you're around 27, I wouldn't be complaining about that as a physician at all. So that part's probably okay. The answer to your question of whether or not metformin will help is it could. The other thing to check is your thyroid. And we use coenzyme Q10, the omega-3 fatty acids, we use inositol, and we use NAC, N-acetylcysteine, as supplements, all of which have been shown to improve PCOS. Will it change your weight? I'm not aware of any data that suggests it alters your weight, but I'm not sure at 27 that you need to be worried about your weight that much. I'd be thrilled. I mean, if all of our patients were in the 27 range, we would not be asking them to lose weight. We'd be perfectly fine with that.
I'm currently 4 weeks, 5 days, and had a tiny bit of blood come out an hour after using a suppository. Should I be concerned? I've had 0 symptoms.
No, I mean, it's always good to be cautious until we've seen a heartbeat, and you may want to get your beta checked. So the beta should still be rising at 4.5 weeks. And so you can go get it checked, and then 48 hours later, get it checked again. But spotting from insertion of a vaginal progesterone is never really a big issue. We see that pretty commonly. And some implantation bleeding is often very common. So I'm not worried about that at all. But make sure they've got an early ultrasound booked for you. And also make sure that you don't have any pain developing on either side. You're not feeling lightheaded or dizzy, excessive pressure in your pelvis, because we don't want to miss an ectopic pregnancy.
Are the chances of miscarrying higher being an IVF patient?
No, depending on what's done, they can be lower, especially with something like PGT in the right circumstances. You all know that I'm not a believer in all circumstances. So it can be lower. We're not really seeing a high rate of miscarriage and never have with our particular IVF program. It's on the order of about 5 to 7%, whereas normal miscarriage rates are about 1 in 6 pregnancies, or close to about 17%. So our rates are a lot lower, but in general, if you read the literature, they say it's about the same.
A lot of people on the gram today.
A lot of people on the gram, nothing wrong with that. Hi,
Is
Grammars.
there a certain amount of time that you recommend post-COVID vaccine before beginning IVF?
Yeah, 2 months. So we just addressed that. So you want 2 months between the time that you take the shot and you do your embryo transfer. Shouldn't have any impact on your egg production, so that shouldn't be an issue at all. But you want 2 months from the first shot till the time you do your embryo transfer.
What supplements should be taken to produce good egg quality for women who have had 2 miscarriages and trying to conceive naturally?
So if you've had 2 miscarriages in a row, you qualify for recurrent pregnancy loss assessment. So I'd actually recommend you get an assessment first. And that's something we specialize in as fertility specialists. So I definitely take a look at that, because there could be other reasons other than just, needing supplements. Something wrong with the shape of your uterus, the fibroid we mentioned earlier, infectious problems, genetic problems, problems with your blood clotting, the hormonal issues, sperm quality issues. So there's a whole host of things that can be addressed. Having said that, the supplements we always use are the prenatal vitamins with lots of folic acid. You want iron, you want vitamin D, which actually does reduce miscarriage rates. Coenzyme Q10 is often beneficial. NAC if you think there's an inflammatory process going on. Inositol if you have PCOS. And we use melatonin for our patients because it does improve fertility. So there are a host of supplements that can be useful. We also use probiotics in our patients now based on the vaginal microbiome data that's out there. So there's a load of things that you can do on a supplement natural kind of level that will improve things for you. I'm holding one of these little bubble levels because I'm always fidgety. But what you want to do is achieve balance. So this is a great little, yeah, you want balance, right? So you want your body to be very neutral. You want everything to be kind of harmonious. I know it sounds hokey in this super scientific world that we're in, But the truth is, there's a lot to that. You know, look at traditional Chinese medicine. I mean, that's most of what's practiced in rural parts of China, and there are close to 2 billion Chinese people. It's not from a lack of what they're doing working. So I really think that there is a lot to having a holistic approach to healthcare that involves the natural approach to things, the holistic approach to things, the naturopathic, the homeopathic, the traditional Chinese medicine, the acupuncture, and so on, and then as well what we do for you. So it's best to approach this holistically in order to get the best outcome, for sure.
Are there fertility benefits to be gained from DHA, or is it more for taking one pregnant?
So no one's actually been able to show a fertility benefit overall for DHA unless you have PCOS, in which case there are studies that suggest a benefit. However, it does improve neural development in the fetus, and it's a very good anti-inflammatory, very, very good. So there's nothing wrong with that. I actually published a paper in Fertility and Sterility, 17 years ago now, I think, 16 or 17 years ago, where we used DHA to see if we could alter markers of inflammation that are related to adhesion formation in the human body. And sure enough, it really makes a very significant difference in the inflammatory markers, thereby meaning that we could improve or reduce the amount of inflammation that was occurring. So it is very potent at that, and therefore helpful in and before a pregnancy and during a pregnancy for sure, but there's no like hard scientific data in the non-PCOS population.
After taking a D&C pills, vaginal inserted, how long do you have to wait to safely have unprotected sex to try for pregnancy again?
So if you mean you took misoprostol to affect a miscarriage, you just have to wait till you had your period and then have the bleed. About 2 weeks later, you can start having intercourse, but you can start trying for a baby with the next normal period that occurs.
Would the lower cycle be ideal for someone who has no fallopian tubes but no previous issues conceiving?
I'm still not a believer in mini IVF yet. I haven't seen enough data to convince me it's better than conventional IVF. There are some studies that suggest that if you have too many eggs, your egg quality goes down. I probably believe in that. But I don't necessarily think that the opposite, where you don't get enough eggs, necessarily yields a benefit. So, I mean, when they're talking mini IVF and then they're getting 9 to 15 eggs, that's not really mini IVF. The whole idea behind mini IVF, aside from the fact that you take a lower dose, is to not get that many eggs. So if you're taking enough to really stimulate the patient, it's not about doing a mini IVF. It's that you didn't overstimulate the patient with drugs they didn't need because you were going to get 9 eggs anyways. That's not really what the whole original purpose of mini IVF was. So, you know, your specific circumstance, I don't think necessarily that that's the right way to go. Depending on age and a whole bunch of other factors, you know, we can determine what the right dose for you is. And I do have patients where we use low doses. I just did it for someone recently. But it all depends on what's going on and what the case is.
I got a good question.
Okay, good question.
Hi, Dr. Victory. I was starting to read the book, It Starts with the Egg,
Right.
by Rebecca Fett.
Yeah.
And I read that melatonin and slow the response of eggs if it was used the long term. What are your thoughts on this? I've been taking melatonin for about 2 years and just want to make sure this is a benefit as opposed to not.
I've never seen any data that suggests that. I'd certainly be open to looking at a study, but I would be very hesitant to believe that there is any evidence looking at a more than 2 year or even more than a year's worth of data on women that took melatonin for that long and then followed their fertility outcomes. That would be like multi-million-dollar studies because it would take so much money to prospectively follow those women. And if it's not prospective, it's really hard to know if that data is worthwhile or not. So I'm not aware of anything, but we can definitely look it up for you. Why don't you DM me and I will look it up and I'll let you know. Good question. That is a good question. Yeah, you did tell me. I don't know, but I'll find out. I'm certainly not aware of any long-term melatonin studies.
Can you take melatonin while pregnant?
Yeah, I do it for all my pregnant patients who need to sleep.
Hi, Dr. Vic.
Dr. Vic, hello.
My husband took the vaccine yesterday.
Awesome.
Is it safe for us to do IUI next month, or we should push it till May? Thanks.
No, for sperm it's fine. There's no issues. Yeah, you can go ahead and try. Not an issue at all.
Dr. Victory. Do interlupins help with the transfer? That's how it's written.
So interlipids can help. There's some mixed data on interlipids. If you look at our video, oh gosh, it was probably last year sometime where we talked about what has evidence for efficacy with recurrent pregnancy loss. There are some studies that suggest that interlipids can be helpful. None of them are like really amazing studies, but there's one in particular that shows that it may be beneficial. So we do use interlipids in our patients where we are worried about an immune problem. We use it in our patients who have failed multiple times, but we don't use it for everybody. Should we? I don't think so, because so many of our patients are getting pregnant without the interlipids, but there are some, and we do use it. I've been using it for, wow, it's been a long time, probably close to about 11 years now that we've been using interlipids, and we probably have several people a month on it. So, you know, out of like 40, 50 patients IVF-wise that we're treating, we probably have, you know, 10% of them, maybe 15% of them on interlipids. Yeah, reasonable.
Big question.
A big question. Okay, I'm ready for the big one. Bring it on.
Hey, Dr. Victory. My cycle is about 35 days, give or take a day.
Okay.
I used to be 28 days with 5 to 7 days bleeding.
Okay.
Over the last year, I have now gone to a 35-day cycle and literally only have my period for about 15 hours.
Oh.
After about 15 hours of a normal flow period, I go to spotting for a few more hours. But by the 24, 30 hour after I start my period, it's done and over with.
Okay.
Is this normal? Is this something I should be concerned about? My family doctor days says, since I have a period every month, there's no concern. If this is something that could be concerning, who should I see or ask to be referred to, as we are wanting to start trying to get pregnant, and it throws me to figure out my ovulation cycle?
So first of all, a 35-day cycle is a bit of a longer cycle, and that can hamper egg quality, and that bleeding pattern is definitely not normal. So I would actually come and see a reproductive endocrinologist and fertility specialist so we can do a workup. There are cases where that could be related to something like polycystic ovarian syndrome, and on the flip, or weight gain, which obviously a lot of us have suffered during COVID. And the flip side of that is it can also be a marker that your ovaries are getting weaker. So if it's PCOS, we can address it. If your ovaries are getting weaker, we got to hurry. So definitely come in directly to see a fertility specialist.
That's a big question.
That was a big question.
Does...
And it didn't start with Dr. Victory.
No, it did not. It did not. That's how people write. Yeah. Does cholestasis of pregnancy always mean early induction for the mom?
Does cholestasis of pregnancy mean early induction for the mom? Yes, because cholestasis of pregnancy has been associated with spontaneous intrapartum fetal asphyxia, and stillbirth. So we actually deliver those moms early.
How successful are natural IVF cycles? 37 years lean PCOS.
Well, if you're PCOS, there's no reason to do a natural IVF cycle because you can make lots of eggs and you want to make lots of eggs. If it's a religious reason or a moral ethical reason, they're reasonably successful. not as successful as conventional IVF. So remember, you're getting one egg, maybe maximum two. We've actually had very good success with it throughout my career. I'd probably say overall average somewhere around 30-35%, but it's certainly not the 80% we're getting when we're doing a full cycle for you. So it's reasonable, but you know, you're getting one egg. So depending on your age and your overall health and what else is going on and the sperm quality, it can really vary as far as what the success rates are.
Ready?
I'm always ready, man. Bring it on.
Had IUI in January and missed my period, but BFN. Unprotected to help my cycle start. If you don't get a period, does that mean you have a ovarian cyst?
No, not necessarily. It could be from hormones. It could be from stress. It could be that you need to get retested because your big fat negative BFN actually is a positive and you didn't realize it. So there's a host of different things. Get your thyroid checked, make sure that there isn't a cyst. I mean, that's a possibility, but it's definitely not an automatic. And cysts don't necessarily delay your period. Yeah.
Any studies on lean PCOS and overweight PCOS and success rates / egg reserve?
Egg reserve is usually excellent with both. I'm not sure I've seen any comparative studies, but egg reserve with any PCOS is typically very, very good. The lean PCOS patients are actually in some ways harder to manage than the other patients are. So it varies from patient to patient, but both should have very high ovarian reserve. Typically, the patients with PCOS that are not in the lean category tend to have a higher ovarian reserve than the ones that are in the lean category, but they're both high.
Love Mara, big heart.
I love Mara too. She's mad at me, but we won't discuss that. Yeah. I love you, Mara.
Hello, Dr. V. I had my blood test today and the clinic said I had low positive 7. Had a low positive 7. Does that mean the cycle failed? I'm at 12 DPO. Thanks.
It certainly could. I mean, it doesn't mean you failed. If you're at a 7, you're positive. But we would need to see, you know, what happens with it. So we would bring you back in 48 hours and check it again. So it's possible that it's a failure. It depends on how far out you are from the appropriate time to test.
Got a good one. Any tips to help the lining become
thicker?
Trilaminar. Of course, my lining wasn't pretty last time. I tried FET. Told you I'd like this one.
Yeah. So there's nothing that will make your lining trilaminar. And if it's not trilaminar, it needs thorough evaluation. So you may need saline infusion sonohystogram, hysteroscopy. You need careful hormone assessment. In some cases, you even need a biopsy. So it all depends on what's going on. The vast majority of women with a healthy uterus should be producing a trilaminar pattern because it's the base of your endometrium, which is called the basalis, and then the interface between the endometrium and the next upper level endometrium. So there's the bottom of your uterus and the top of your uterus, or front and back if you want to look at it that way. And so the interface between is one line, then the bottom layer is another line, and the top of the top layer is another line. So you should have a triple layer. Women that don't have problems with the growth of the endometrium, scarring, adhesions, infection, fluid being in there, fibroids, polyps, inappropriate hormonal exposure. So there are a variety of things which can contribute to why you would have an abnormal or not triple layer lining.
Are there any downsides to long-term metformin use?
No, in fact, in the journal The Lancet, which is arguably number 1 or 2 in the world, up there with the New England Journal of Medicine, several years ago, there was a study demonstrating that patients that were at risk for diabetes, such as all PCOS women, who stayed on metformin actually delayed the onset of the diabetes. So there is no downside to using it as long as you're not abusing it and it has no impact on your liver function or anything like that. No side effects for you.
I'm 40 years old and did my first IVF cycle.
Awesome. Good for you. That's amazing. Congratulations. And we will all pray for you and hope that that works.
Are max dose stims good for DOR, age 32, AMH 7.2, AFC 10 at baseline? Day 6, no response so far.
So that's really interesting. That's not DOR. I mean, if you've got 10 eggs, you don't have diminished ovarian reserve. So in your case, I don't know about a max stim, but a high dose protocol would be appropriate, or at least the standard dose protocol would be appropriate because you're capable of making 10 eggs. We want all 10 of those eggs. So you're not DOR. If your AMH is 7 and your AFC is 10, you don't meet anybody's criteria. I mean, there's Bologna criteria for diminished ovarian reserve. You're not hitting any of them. So I don't know who told you you're DOR, but you're not DOR. So stay with a normal stim or duo stim. We love duo stim. I'll tell you a great story about duo stim. Two, in fact. I had one patient who we did duo stim for, and her first batch of eggs that she produced, we got all of the eggs fertilized, and she actually made a fair number, and none of them turned into blastocysts, which was bizarre because, like, I was expecting at least some of them to turn into blastocysts. None. So we continued on. We did her duo stim cycle, and we got another batch of eggs from her, and then we made the embryos and we sent them for PGT testing, just, you know, for a variety of different reasons, and the results we got back were great. So she ended up with 4 blastocysts. 2 were normal, 1 was not. 1, they didn't have enough DNA, but that's still very hopeful that that one is normal as well. And either way, we have 2, which is a very high chance of having a live birth. So duostim works really, really well. The other duostim story we had was another patient recently who did her first cycle and then did the second. We got 11 eggs out of her mature on the second try. So that's like really amazing results that we were not expecting, because in her first stim and in her previous stims, she has not been making very many eggs at all. So there is something to the duo stim, and it is working well for us. So we're doing it quite a bit. And we discount it to make it cheaper for you guys because we know it's already a bad situation when you need it. And so we've allowed patients to jump into it. We've allowed patients to start it and stay in it. It's worked remarkably well for us. Excuse me.
Continuation from the 40-year-old. So.
The 40-year-old. I just tried IVF. I got it. Okay.
I'm 40 years old, just had my first IVF cycle, and only retrieved 1 egg. Was diagnosed with low ovarian reserve and empty follicle since. Should I do another round of IVF?
There are patients that have empty follicles. We see this every day when we do egg retrievals. You go in the follicle, you drain it, nothing comes out. You can flush it like a dozen times, you still won't get anything out. So there are some follicles that are empty. However, in general, if the follicle is, if you're not getting anything out, either there's something wrong or you haven't released the egg. It's still stuck to the wall of the follicle itself. So if you have diminished ovarian reserve and you're only producing 1 follicle and you're 40, honestly, it depends on your finances. So first of all, I would only do natural cycle. I wouldn't try anything else because it's probably not worth it. Secondly, you need to factor in the costs emotionally, financially, psychologically, all of that. And you need to decide if it's the right thing for you. And thirdly, you got to decide how comfortable you are with the alternatives, not trying and not having a child, or another child if you already have one, trying and failing and having spent the money for it, or, you know, whether or not you're comfortable with using a donor where your success rate can be amazingly high. So or doing adoption or any of the other things that are available, embryo adoption and so on. So it all depends on your comfort level with what you're doing and the costs. And I don't mean the cost just financially, although that's critical. But I mean, all of this stuff takes an emotional toll. It takes a psychological toll, a spiritual one, a relationship one in many, many cases. So you need to factor all of that in there. Yeah.
You got 1 minute. Just
1 minute to 9 or 1
4
minute
minute to 9.
to 9? All right. Well, lately we go to 9:15, but that's okay.
Are there any negative effects after a prolonged metformin use for PCOS and weight loss assistance?
No, just answered that one, so we're good.
Thank you for this great Q&A. What dosage do you recommend for coenzyme Q10 and NAC for PCOS patients?
NAC's 1,000 and coenzyme Q10 is 600.
I'm losing weight during IVF without any explanation. I have been taking
Levothyroxine.
There you go. 50 milligrams for 2 years now. My TSH levels were at 1.38 in the last labs.
That's perfect.
What could be the reason?
Stress, healthy diet, Mediterranean diet, all sorts of different reasons. Your thyroid TSH might be normal, but make sure your T4 is not too high, because if your T4 is high, you will end up having a overdrive of your thyroid, and that can make you lose weight. So there could be a variety of different reasons.
I've had 2 successful IVF transfers, but has resulted in loss. Both pregnancies didn't further develop after 8 weeks. Genetic testing, fine, and recent referral. Fibroids told, not the cause. Any advice?
I could not understand that one. What? Okay, I've had 2 successful IVF transfers, but result in loss. Both pregnancies didn't further develop after 8 weeks. Genetic testing fine and recent referral. Fibroids. Told not the cause. Advice. If you have fibroids, it depends on where they are and how big they are before we can determine if they're the cause or not. It could be genetics of the embryos. I'm not quite sure how they would have tested them after the fact, although that is possible. So if they were genetically normal and you are miscarrying genetically normal embryos, you need a very thorough evaluation. So you need an assessment of infection in the lining of your uterus. You need your vitamins checked. You need all your hormones, including thyroid antibodies, checked. You need to be looked for a thrombophilia. You probably need your immune system evaluated. You need a very detailed look at your uterus, including how big the fibroids are they indenting the cavity, and so on. So there's a lot of stuff that goes into a case like that.
Hi. I got Lupron on January 8th, but it didn't work because Mr. E2 drops after 12 days injection. Should I cancel my cycle when my period will be back after Lupron?
So your Lupron shot doesn't always drop your E2. It depends on a lot of factors. It should drop your E2, but it won't always drop your E2, and it can take a while. It depends on how much Lupron you took and which version of it you took. So that's a complicated one to answer. Follow up with us or whoever is taking care of you, and we will make sure we look into it.
My daughter is 2.
Your daughter is 2?
To
Whoa.
try again.
Okay.
I want to try again.
Oh, okay.
I am 41 now, but am I too late? No health issues. We beat the odds last time. We can do it again. Do I need a referral to see you?
You do need a referral if it's been 2 years, unless you've stayed in touch with us. We definitely can do it again. And if you beat the odds once, why not try again? For sure. We'd be happy to help you out. And congrats on the little one. Send pictures. I love seeing the babies we've helped.
What is the highest successful multiply pregnancy you have followed? And was it IUI, IVF, or embryo splitting?
Oh, okay. So as a resident, we had 1 set of quads. That's never a good thing. It was the only set of quads that made it. I've had many triplets. I have one now. I just saw her today. We've had many triplets, so that's fine. We've had loads of twins. If you have more than triplets, the recommendation in the strongest terms is to reduce. There can be complications with reduction, but overall it tends to be safe. So the highest number we've ever had, which quite frankly was bizarre, was 5. And I still to this day have no idea how that happened, because none of her eggs were big enough to produce babies, but they did. So she had something really wonky going on, and she reduced, and actually she did great. She carried the rest of the pregnancy. She reduced down to twins and did wonderfully. Obviously, that's a horrible, horrible thing to happen. And I fear for my soul when I am responsible for babies that I have created that unfortunately have to be terminated to improve the success rate for their siblings. So we don't like making triplets and quadruplets and quintuplets. You know, knock wood, it hasn't happened often. There's some wood down here. Yeah. It doesn't happen very often. We get about one set a year of more than twins, sometimes two, but it's pretty rare. Yeah, and certainly with IVF, we're pretty much almost exclusively doing single embryo transfers now, and we're still getting these incredible success rates. So you don't need to put in a ton of embryos. You just need a really good lab, a really caring team, and a really good protocol. And as long as you guys are doing your part, we'll get you pregnant. It may take 1 or 2 tries, but you'll get pregnant.
Okay. Does the study say what percentage of embryos made it to blastocyst? Is it possible that this approach could help patients who are having a hard time getting blasts with conventional IVF?
It said that about 50% made it to blast. So that's average. I have seen, and I am a believer, that there are women whose eggs don't respond well to the meds, or at least the embryos don't respond well to the meds. And as a result, they end up with not great embryo quality when you give them lots of medication, but they actually end up with great embryo quality when you don't give them lots of medication. And those are the ones where we do natural cycle IVF, where you just don't give them any meds and you make one egg and you turn it into an embryo. I don't know that mini, in my mind, makes any biological sense as far as, you know, altering egg quality markers or, you know, metrics, but natural does, because you're taking such a low dose for such a short time. It really should have almost no impact whatsoever. And we have had good success with it. So yeah, if you've tried normal IVF and you're getting bad embryo quality, the next go-to, assuming you can afford it, is to try natural cycle IVF, where you're taking minimal to no medication. You just, you know, wait till the follicle's like 13, 14, you start Cetrotide or Orgalutran. You take maybe 1 mini dose of a medication, Gonal-F, Menopure, whatever your doctor likes. And then you do that for about 3 days. The minute you hit like a 17, maximum 18 millimeter follicle, you trigger and you go and you fetch the egg.
You have a lot of questions.
We do? Mm-hmm. Are we going on forever?
No.
What time is it? 9:07. All right, we'll give you guys a little more time. 8 more minutes.
So this is a nice comment for you.
Okay.
Hi, Dr. Victory. I am religiously follow you and love seeing you live. You are doing an amazing job by answering fertility questions. May God bless you always.
Thank you very, very much, and God bless you too. God bless all of us. We need it these days, so thank you. And I am blessed. I'm surrounded by amazing people like my friend Tarek, my incredible team at work, my amazing, amazing family, my wife, my kids, my phenomenal mom who I look up to in every way, and my dad who is a unique test of any human being's strength. So, yeah, you know what? I'm surrounded by good people. I love my God. I'm a really religious guy. So, you know what? I'm very blessed to have the people in my life that I do. Each one of them is equally important, and everybody that's here is amazing. So, and I have to say, without a doubt, that without Mara, I could not have built VRC. It's as much hers as it is mine. So I love you, Mara.
If I have only one euploid day 6 frozen embryo at the age of 38, should I go into IVF cycles or try the FET? I've had 3 failed untested FETs prior.
Oh. It depends on how many kids you want to have. So if you're thinking of having more children in the future, you probably should start banking embryos now. If you're not thinking of having any more children in the future, I don't see what the harm in trying this one would be, because you'd get pregnant, hopefully, and then you have the pregnancy, and if it doesn't work out afterwards, you have your one child. So as long as you're content with that now, I don't see a reason why you can't go ahead, because it'll save you a ton of money. But if you want more than one child, or aren't sure if you want more than one child, you kind of are obligated to go ahead and make more embryos. We call that embryo banking, because you don't want to end up in a situation where down the line your chances are even lower for producing good embryos, and now you gotta do it later on, and now the chances may not be there to even get one genetically normal one. Great question. Very, very good question. Thank you for asking that.
Does having diarrhea a couple days during the alluvial phase affect conception? Thanks.
No, although there are women that get gastrointestinal symptoms in the luteal phase related to endometriosis, one of which can be diarrhea. So if it's really bad, make sure you're evaluated to make sure you don't have endo.
If IUI fails, moving to IVF ASAP, how long does it often take to start paying out of pocket? Do many PCOS patients take birth control first, using frozen sperm from before hubby's cancer treatments?
Okay, so most PCOS patients with us go on the birth control pill because we want to normalize your hormones. How long before you start paying? I'm not sure what you mean. We take a deposit, and then before you actually start your stimulation phase, you need to have paid in full. I think that was pretty much it, right? Yeah. Frozen sperm won't make a difference. So, and I'm sorry your husband had to go through that treatment. I hope he's well, and our prayers are with him.
Hi, Dr. V! Exclamation mark, exclamation mark. How many hours of progesterone and oil should you have before transferring a frozen 6-day embryo? Does it matter if you take PIO at night or in the morning? Thanks. You are amazing. Applause.
Thank you for the compliment. So you should take your PIO in the morning of the day that you're supposed to start your progesterone. The idea being that you're supposed to have 120 hours of progesterone exposure prior to your embryo transfer. So if you take it at night, you're not really getting 120, you're getting less, unless they're mixing vaginal and PIO, which we do, but you're still probably not getting the same impact. So you should be taking it in the morning. You should have a minimum of 5 days, but we actually reviewed a study on the show where we compared 6 or 7 days of embryo transfer. So if you're getting 5 days of progesterone, you're actually transferring on the morning of day 6. And if you're getting 6 days of progesterone, you're transferring on the morning of day 7. If you go to our YouTube channel, it's one of the popular uploads. You can see it very quickly. It's got kind of a purple background that says 6 or 7. And I guess I'm supposed to point up here or something. Tarek's going to put the link up for you. And so in that video, they showed that the miscarriage rate was lower if your day 6 embryo went in after 6 days of progesterone. So that's what we do. If we have a day 6 embryo, we put it in after 6 days. If we have a day 5, after 5. Yeah. Day 5s can actually go in day 5 or day 6 with no difference in outcome, which is, by the way, why the ERA test is useless. And the ERA test is useless. But day 6, it's my favorite topic, isn't it? Yeah. But day 6 should go in after 6 days probably, because it reduces miscarriage rates. The outcome was the same, but the miscarriage rates were higher when you did it after 5, lower when you did it after 6.
Too fast. I don't know how I'm supposed to pull these things up.
You're amazing, man. Come on. We've been doing it for 2 years almost now. We got to have like a Fact or Fiction anniversary.
I have an idea for Fact or Fiction.
We got to figure out what the first one we ever did was. I don't even remember. Hey, we'll find some kind of prize to give you guys if one of you was there at the very beginning and remembers what the actual date of the first Fact or Fiction that we did was. I cannot remember anymore.
That's a good idea.
One more question. It's 9:14. The wife's going to kill me.
One more question? Do you want me to pick one, or you want me to go to the next one?
No, go pick a good one.
All right. Get ready. The YouTubers are on fire today.
The YouTubers are on fire. All right, welcome
serious.
YouTubers. We love YouTube. YouTube channel is growing like crazy. Instagram, impossible. I need you guys to tag us in all your comments and stuff. Growing Instagram is a nightmare, but YouTube, like every morning I wake up, we got 10, 20 new followers.
All right, you ready?
Yeah.
I got something.
Yeah.
I got a lot, but I'm hoping this is a good one.
Okay.
All right. 38 years old.
Okay.
Hashimoto's, PCOS. Okay.
Okay.
On metformin.
Okay.
Inositol.
Yeah. Levothyroxine.
Levothyroxine. I'm day 53 of period. Tried both Provera and birth control to stop it only for this cycle. All it did was slow it down. And what other option? What? Yeah, slow it down. And then right below says, what other options would you be thinking about? I'm having an ultrasound this Thursday.
Yeah, you need an ultrasound because you may have overgrowth of your lining, like endometrial hyperplasia. You got to look for a cyst. You need all your hormones rechecked, in particular your thyroid if you have Hashimoto's. So that's a complex situation. It needs evaluation and it needs gynecologic evaluation. So make sure you see one of us right away. Let's do one more.
I got another good one.
Yeah, give me another good one.
This is a Facebooker.
Okay, a Facebooker.
36 years old.
Okay.
F.
Female. Okay.
Okay. I was wondering what's... Sometimes I think these things are typos, you know? But
Okay.
you always look like you know.
Hello, my 36-year-old Facebook female.
Yeah. Never pregnant.
Okay.
Tried first IUI last year, but
Okay.
it didn't work.
Okay.
Currently, I'm going through something called as vaginism.
Vaginismus. Vaginismus. Yeah.
Okay. Has been having tight foreskin and probably dysfunction. Haven't had intercourse since long time because of pain. Now waiting for vaginismus treatment. Once this vaginism is resolved, then we'll go through IUI again. I'm worried. I'm already 36 years old and going through problems like this. Are still chances with IUI and IVF treatments?
Okay, so first of all, vaginismus is relatively easy to treat if you do the right thing. Buy a vibrator, use it 20 minutes every day. It will desensitize your nerves. So this is like a dildo vibrator, like one that looks essentially like a penis, is roughly the same size. There's different ones you can get. You can get narrower ones and use those first and then graduate up to one that's roughly the size of your partner. 20 minutes every day, it will numb the nerves. As any woman that has used vibrators repeatedly knows, it gets a little bit harder to achieve an orgasm because you do get some desensitization if you use it repeatedly. So that's beneficial for someone with vaginismus. So all you really need to do is use a vibrator. As far as your age, is there a big difference between 36 and 36 and a half or 37? There's a difference. I don't know that I'd say it's a big difference. So between 36 and 36 and a half, no. Excuse me, but if you're waiting longer than that, you're looking at, you know, like 37, a year, 2 years. Sure, there's going to be a slight decline. Again, it depends very much on your ovarian reserve, how strong your ovaries are, that kind of thing.
Another one? I got one. I'm nonstop here. I think I can go on for another hour. That's the kind of
Seriously?
material I got. Yeah, look at this.
Oh my God, that's crazy. Let me take one. All right, you do yours. I'll go from here.
Okay, which is best? IUI with gonal F, centrotide, overdrill, or IUI with letrozole only?
Say that again?
Yeah.
Okay.
Which is best, IUI with gonal F centrotide, overdrill, or IUI with letrozole only?
No, IUI with shots is always going to give you a higher chance of success. It's a higher chance of multiples, but it's a higher chance of success. Okay, I'm going to do some rapid fire questions
Go for
here.
it. There's nothing rapid, I don't think.
Oh, I can do them quickly.
All right.
What is the highest successful multiple? Oh yeah, we did that one. What is the lowest graded embryo you've seen become a healthy baby? It was a 2cc. And the percentage on success rates, you can't answer percentage on success rates. for morphology because it's actually kind of meaningless, so ignore that completely. Is underweight affecting PCOS, and what should be considered underweight? You need to calculate your body mass index. If you're under like 20, 21, it does get harder to get pregnant. Thank you for giving us this opportunity. Is it safe to have teeth removal while on Menopure? No. If you're infected, stop your IVF cycle. If you are not infected, then definitely do not get your tooth removed. There's all sorts of bacteria that enters your bloodstream. You don't want that. Would I ever recommend putting 2 embryos in one transfer? Untested, over the age of 38. Pgt tested over the age of 38. I'm fine with putting in 2 because the likelihood is high that at least one of them isn't normal. Are there any supplements to help prevention of cysts? No. There are no supplements to prevent you from making cysts. Oh, I hate your keyboard, you know that? Would you say it's more difficult to become pregnant after a miscarriage and D&C? No, only if they harmed your uterus. Make sure you get checked if you're not finding success. Thank you, appreciate you responding to me. I am eligible to get the vaccine. Should I get it or should I wait? If you can get the vaccine, get the vaccine. We need this pandemic over. And you need to wait 2 months before you try to get pregnant from your first shot. Would an ultrasound finding of a functional cyst, acne, and some excess hair mean PCOS if menstrual cycle is regular? No. This is a really surreal experience because I'm seeing myself talking here as I'm reading these questions. So no, PCOS is a clinical diagnosis. So the acne and excess hair can mean PCOS, but not a functional cyst. Lots of little eggs on ultrasound contributes. Thank you, Dr. V. Oh, I love you, Sheely. That's okay. You are super awesome. What kind of treatment does the future mom and the surrogate have to take when starting the surrogacy process? The mom has to take the meds for IVF. And then later, once the surrogate is pregnant, we can get the mom to make breast milk even if she was never pregnant. The surrogate needs the medications we use for a frozen embryo transfer. Done.
You're the man.
I'm the man. All right, guys, rapid fire. You know what? We'll add that to the end of the show. Last 5 minutes, we'll do like rapid fire questions. Okay, so my wife's going to execute me, and my son needs me to help him out too. So I am going to head home. Wonderful show. I really enjoy these opportunities to reach out and help you guys. Don't hesitate to contact us if you need help. We are always here to help people from across the world. I talk to people from Sweden every morning. England, Ireland, multiple times. They do not seem to have great care in Ireland. We've got patients in Scotland, in Japan, all over the world. So all over the US as well. So if you need us, VRC, we're here for you. Have a great night, guys. Take care.